At the outset, I'd like to thank Dr. Bhattacharya and Dr. Pal for giving me this opportunity. Well, I'm the odd man out. I'm the only retinal surgeon among the galaxy of cataract surgeon and anterior segment surgeons. Well, my topic is the landmine behind the dark or mature cataract in retina perspective. Is my presentation visible?
Yes.
So no wonder there is a dramatic linear increase in the rate of cataract surgery. But what will be the outcome when we can't see what's there behind the mature cataract like this? And in a developing country like us, the cataract being the leading cause of the blindness, and unfortunately, many patients visit at the mature cataract stage. And while selecting this, there might be some poor selection of cases when the fundus is not visible and which might lead to unhappy patients. Now, the primary investigation, what we do in a mature cataract or a brown cataract, is a ultrasonography. Ultrasonography can give some information regarding the retina. There might be a retinal detachment. There might be some vitreous hemorrhage with subhyaloid hemorrhage. There might be staphyloma or some choroidal mass. But what about the other common diseases that can't be detected preoperatively by the ultrasonography? Like if there is a diabetic retinopathy and there is a mature cataract, we cannot judge what is the severity of the diabetic retinopathy. We can get some idea seeing the other eye, but exact situation of that eye is we cannot predict. Similarly, the diabetic macular edema, it is very difficult to predict what is the grade of the diabetic macular edema, whether it is present or not. And OCT has a very minimal role in a hazy media like mature cataract. There might be a CRVO, BRVO, which is also very difficult to predict what's there inside. If there is some epiretinal membrane or a macular hole or a vitromacular traction, there can be an choroidal neovascular membrane, or there can be some optic disc anomalies. There might be a possibility of hereditary disorders like retinitis pigmentosa, although it is a bilateral, but rarely it can present as a unilateral case also. Inflammatory disease, whether it is an active disease or a scarred choroiditis is there, we will not be we cannot diagnose seeing the anterior segment. We can have a history, obviously. So a proper history is definitely very important. Next comes the investigation. The macular function test evaluates the potentiality of the vision in the eyes with opaque media. As we know, the macula has the highest discriminative ability and responsible for the color perceptions. Now, what are the macular function tests in the opaque media? There is a battery of tests: Maddox rod test, focal ERG, VP, laser interferometry, the PAM, the entoptic phenomena. But what is important, we can just highlight few. The commonly used investigations like an ERG, which will actually give us an information on the health of the retina. What is the function of the retina? The A waves gives the photoreceptor function, and B wave gives the molar cell and the bipolar cell activity. We are not going into the details of the ERG interpretation, but definitely information of the rod cell response and the cone cell response we can get through the ERG. In RP, if there is an RP, and especially unilateral RP, which I was mentioning, we will get a flat ERG response. Even in the congenital stationary 9 lens, there will be a flat ERG response. There is a negative ERG also. Cone dystrophy, we will see the 30 Hertz flicker response and the photopic response totally flat. In CRAO, we will get a negative ERG. BRVO and CRVO also, there will be a B wave, reduced B wave amplitude, reduced B2A wave ratio, diminished, the prolonged B wave implicit times, and multifocal ERG actually can pick up the macular pathologies. That is, a localized effect can be picked up by the multifocal ERG. As in this case, the macular hole, we will see the responses in the central 5 to 10 degree will be diminished. Same with the epiretinal membrane. When there is an optic nerve problem, that can be easily detected with a VEP, which represents the integrity of the entire visual pathway. If there is a problem with the amplitude, so we can actually diagnose there might be some ischemic disorder. If there is a problem with the latency, if the latency is prolonged, then there might be a demyelinating disorder. If there is a history of trauma, and there is no recordable ERG then we have to explain the prognosis, where in fact it helps the surgeon to decide whether to go ahead with the surgery or not. There are other tests like laser interferometry, the potential visual acuity, which can actually give us an idea what will be the vision like after the cataract surgery. So these are very important tests, but unfortunately it is not available at all places. So the pearls are, if all the tests it's not possible to get all the tests. So the more important things are, we need to check for the RAPD, look for the projection of rays, and if the color vision is possible, which gives a cone function, the macular diseases, we can get a blue-yellow defect. In optic nerve disorder, there may be red-green defect if it is permissible. And macular function test, if it is available, we should go ahead if there is a clinical suspicion or there is some doubt from the history given by the patient. So the take-home message is a detailed history and a B scan, an assessment of the macula and optic nerve function is very important. The preoperative counseling, that is short and long-term prognostication, informed consent process in terms of relative risk and benefits of the surgery. This is the most important, as we know that no test of retinal function or macular function has 100% sensitivity or specificity. We have to depend on the detailed history and the clinical findings.